Hello and good morning, everyone. It's lovely to see you. I am supposed to be here.
I did promise this was a joint presentation.
So my name's Helen, Carey. I'm working in Florida as Programme Director. I've been working with ALS MND for a long time.
My name's Sarah. I work in Australia at the statewide Progressive Neurological Diseases Clinic, which is the statewide MND clinic in Victoria. I'm also the daughter of someone who lived with MND, so I come with sort of two angles to this.
And I'm also the daughter of somebody who had MND, so we share lives together.
And this is actually the first time we've met in person.
So we met earlier this year. Sarah was presenting. I'm going to be honest, I was like, oh, here's another occupational therapist presenting, and I'm sure they're going to talk about adaptations and equipment, and it's going to be the same thing. And Sarah came on, spoke, and I was like, yes, somebody who thinks quite similar to me. I've talked about exercise and positive tiredness, so you can see where my mind goes with motor neurone disease, trying to work as an allied health profession positively with this disease, and she thought exactly the same as you. So it's not going to be any surprise that we're talking today about embracing risk and how we enable people with ALS. So with no further ado, I counted up 43 years between us working with people with MND ALS. And what we're going to do is be challenging you to talk about how you can embrace risk rather than be risk averse when working with our clients. So hold on to your seats. This is going to be a critical look. We want you to think, we want you to reflect, we want you to think about the people that you have treated, the clinical reasoning you have made over the years, and I want you to challenge and think, could I have done that a little bit better? Okay? So the challenge for us here, as you can see, is being able to predict. So predict an individual's progression. You'll all know that as allied health professions. That's really, really difficult. You are, how I always think, one step. You're one step in front, thinking how this disease progresses and how you can compare as you're going along. So, but that sounds great. But positive risk-taking is really important, as well as many of you will know with working with people with MND ALS. And this has been known since about 2004. Yet, interestingly enough, if you do literature reviews, there is lots and lots of evidence that occupational therapists discuss us talking about doing are actually the most cautious in our decision-making for enabling risk. We're the ones that talk about safety lots and lots of time. And as I've spoken on before, sometimes prevent doing because of our over-belief in safety. Certainly some of the studies that I've done looked at how lots of people with MND ALS thought that occupational therapists actually limited their engagement due to the preoccupation with safety. So, we ask you this question: what of the activities important for that individual are perceived by health professionals to come with a risk of harm, injury, stress, or deterioration of symptoms? And I'm sure now, while you're sitting here, you can think of many, many cases where this has been a conundrum for you. So we're going to talk here about you taking positive risk-taking. Positive risk. In your clinical reasoning, lean on the side of positive risk. To be able to make sure that individuals live in line with their values, that they're able to achieve their bucket list, that we enable people to live in harmony. Here, let's look here about all the many multiple things. If you look at the circles on the right, the many multiple things that somebody with MND ALS has to think about. Ventilation, medical appointments, having a different future, modifying their home, losing employment, needing to think of the acceptance of their diagnosis, needing the equipment to communicate. A whole host of decisions that they have to take. And do we sometimes give them the full information to be able to think about those decisions? Do we sometimes err on more caution rather than really enabling them to go for risk on what they really want to do?
So I think when you hear health professionals talk about the dignity of risk. People have the dignity of risk to make choices. But I think what I really want to challenge you to do is to ensure that you are giving your clients that you're working with all of the options so that they are making an informed choice to be able to exercise their dignity of risk. Because individuals have the right to not go ahead without recommendations. And essentially they are that. They may be a recommendation. They are not a rule. We are not the masters of everybody's lives, and everybody has different lives, different things that are important to them, different houses, different families, different bucket lists. And as occupational therapists, I would really like to ensure that we are enabling people to do what they want to do, and knowing that there is no clinical pathway to this, and everybody's doing list is very, very different. And that if we're not ensuring that people can do what is important to them, that because we are worried about eliminating risk, then really are we doing what our job is? Our job as occupational therapists is about doing. And so the positive outcomes that they might have that has a small amount of risk involved with it is so much more important than not doing that. Like, I've been following people living with ALS for MND for 15 years. I think of Steve Gleason. He climbed Machu Picchu when he was diagnosed. He got carried up a giant mountain in Peru. We look at Dr. Justin Yerbury from Australia, who at the conference in Perth in 2019, he flew. A lot of people went, oh, you can't fly, it's going to be too hard, you've got too much stuff, you're on a ventilator, blah, blah, blah. Nope, his OT and his physio made some very excellent negotiations with Qantas, our local airline, to get on the plane beforehand to measure it up to make sure that he could get on. You know the other thing he did? He got in the ocean in Perth in a beach wheelchair that was organised because that was his bucket list. Now, there was probably a lot of therapists that were freaking out about that, but he was like, you know what, it's my bucket list, and he did it. So when we talk about dignity of risk versus duty of care, what do we mean by this? So the dignity of risk is the absolute right for a person to choose what is important to them. We do that every day. We choose to get in the car, we choose to get on a plane, to come to Basel. And our duty of care of health professionals is to ensure that we are providing our clients with all of the options, all of the information, all of the knowledge to ensure that the decision that they are making is based on all the information, not just the thing that we are recommending. Oh, I'm on my soapbox. I'm sorry. And so where does this go? This dignity of risk versus duty of care. And often they are presented as a dichotomy. They are opposites, they don't go together. And I would challenge you to try and think of them, how they can go together. Our duty of care of health professionals is to ensure that we can let people try, touch, look at their house, look at what's important to them, look at their families, their support system, and then put into place letting them try the options. Because I think one of the things that I know, that with our speech pathologists, they talk about risk feeding. Fine, seems to be okay, that people get that. The neurologists talk about, yes, to have a PEG or a RIG or not, or uptake ventilator or not. And all of a sudden with OTs, we're like, oh, you can't transfer like that because you might fall. And I just it seemed to me like a real kind of the other end of the spectrum. And you know what? I might fall over too. We all might fall over. And yes, we can put into place things to eliminate the risk of falling over, but if someone still wants to walk around their house holding onto the furniture, when you've explained to them, there's these options and these options, and we might move that mat, and if they don't want to do it, that's okay, that's their choice. These are, adults. There is a balance between providing all the information to allow people to exercise the dignity of risk, and that's what I'm going to talk about a bit more now. How do we facilitate individuals to make an informed choice to choose positive risk. We, as health professionals, need to provide all the information. We need to do a good evaluation of that person, what's important to them, where they live, how they do things. And we then need to trial, because we can't expect someone who's got no lived experience of the way that their body is changing to make a decision without actually trying it. I often hear therapists say, oh yeah, I told someone about, a wheelchair and they said no. I'm like, did they actually get in it? Did they actually have a go? Did they actually see this wheelchair, this wheelchair, this wheelchair, this wheelchair, to look at different, houses and sizes and where they want to go? Do they want to go down the bush? Sorry, that's really Australian. Do they want to go? Do they want to go for a ramble in a forest somewhere, or do they just want to go down to the shops? And that ensuring that the information that we are providing is easily accessible and without bias. It's not up to us. We shouldn't be choosing for people. Sometimes people want help making the decision, and they want, what do you suggest, or what do you think is the best thing? And I certainly will give those kind of opinions, but again, it's my opinion based on a good evaluation. And I always say to therapists, you need to give people, there's this way of doing it, this way of doing it, this way of doing it. And this is the pros and cons and pros and cons and pros and cons and the risks and the benefits and the risks and the benefits and the risks and the benefits. And then the person can choose. So how do we support this decision making? Well, clearly, as I've said, we need to support the individual with their priorities and their values. We need to simplify the decision making a little bit, because this is a language that no one understands. External memory points. Now, I say this as I always will write things down. I even know when I was going through, sessions with my mum, and I'm a health literate person who's worked in this organisation, that I did not always remember everything that everyone said. So writing it down, really important. Multiple times, you might need to plant the seed. In our clinic in Australia, it's set up like an independent living centre for people with MND. And people can walk around and just have a look at things, because they don't know what they don't know. Building insight. Things may change, knowing that the goalposts are going to change. Things are going to change. And that's okay. It's all right to just go along this journey with someone. Now, I think I've probably talked too much now.
You're fine.
No, I'm fine. All right, I'm going to give you a little case study. This is Mr. B. That's me and Mr. B. So he was a 42-year-old man, lived with his wife, his 4 young daughters. The youngest daughter was 5. He was diagnosed with flail upper limb MND, so he had lots of lower motor neuron signs and ended up with very non-functional upper limbs. Now, the first time I saw him in clinic, he absolutely wailed. It absolutely devastated him what this meant for his life, his future, everything that he'd planned to do with his family. He was able to walk and talk, and he really didn't want to engage. He was like, I just want to go and sit in a dark room and not think about this. This is just really, really upsetting for him. And in my very Australian style, I sat at the kitchen table with him one day and I apologised in advance for my potty mouth. And I said, Mr. B, what is shitting you the most about this? And he said to me, sir, I think, what's shitting me? I can't smoke without help. Now, this man probably needed an AFO, he needed a wheelchair, we need to start talking about his bathroom and his access. You know what? All of that went out. That was not important to him. The thing that was important to him was being able to light a cigarette. So, what did we do? I was like, okay, this is part of, getting in with this kind of, ensuring that what I'm doing is important to him. This is the thing that's important to him. We have a thing in Australia called the NDIS, which is our National Disability Supported Scheme, which is where the money comes from. And I put that in as a goal. He wants to be able to smoke. So what did we do? The things he identified as important was he wanted to smoke, he wanted to have a drink, he wanted to walk around his house and his property with his kids, despite this risk of falling, and he wanted to use his computer. So what do we do? I wasn't going to go anywhere around the things that were going to reduce risk, because he was going to push me away as fast as he could. So I was going to look on smoking. But I was really kind of honest with him and went, dude, I don't want you to fall over and break a leg, because that's going to be more disabling. Oh my God, this is what we did. That's a video. There we go. So I worked with his mate and the local men's shed. This was prototype 1. Prototype 2 is on the right. You can see simultaneously we're working on the computer. He's got a Q Harzono head mouse on his hat, which he could get onto his computer with a foot switch. But we hacked an electric arc lighter, which is what the mountaineers use, and we switch adapted it so he could light his ciggy. And then he had a little holder that we made. This was prototype 1. So prototype 2, you see, all came together. He even had like an ashtray. He had the mirror that we got off a car because he couldn't see when the end of his cigarette was going to hit here. And so he burned his lip. There you go. That was my number one thing.
Mr. Let's give you case number 2. Mr. C, 57-year-old, living at home with his wife, diagnosed with MND. Dysarthria, dysphagia, limited upper limb movement, starting to now be a bit wobbly when he's walking. Wanted to eat and drink and wanted to continue to work. He was told quite frequently not to eat, not to drink, not to take any fluids. If we didn't embrace this, he was going to push us away. So he drank pints of beer quite frequently. Without any problem, and was happy with it. Crisps and such like, kept eating and wouldn't use any mobility aids. Did we stumble sometimes? Yes. Did we fall sometimes? Yes. But he still wanted to do it. Let me introduce you, that case study was my dad. My dad diagnosed MND July 97, died at home with us, 98, quite quick. Worked till 2 days before he died.
Quickly, the last case study, Mrs. L, 69-year-old lady living at home, diagnosed 14 months after the symptoms started, lived in a very rural area in Australia, had quite rapid progression of symptoms, had quite a lot of things happen along that way. She also had quite a lot of chronic health conditions, which made the kind of diagnostic period very tricky. Now, she was a stubborn old bird, very country Australian woman. She didn't want an electric bed. She wanted to stay in her bed. The house was small. The house was old. She did have a peg. She didn't love it. She didn't love NIV. She also lived in a really rural area, so to even get a bed, it was going to be literally impossible. And so her therapists were great. They tried to use a hoist, couldn't use a hoist. Her joints hurt, tried to use a standing machine, couldn't do that. Her son was this big kind of burly Australian dude, and the daughter was there as well. And in the end, they just went, you know what, we're just going to lift mum. We're just going to slide her from bed onto the wheel commode. That was the easiest. She also, because of her Crohn's disease, the peg feeds were nasty. There was all sorts of things going on. And she was dying really quickly. She really wanted to stay at home. That was my mum. I slept up and down. She slept in this side of the bed and I slept this way. And my brother and I would get up in the middle of the night, and he is a big, giant dude, and she weighed about 50 kilos by this point. Yes, we did manual handling training. Yes, the physio and the OT talked to us about we tried all the things. But when your mum is screaming and she's in a hoist because all of her joints hurt, I was not going to be doing that. Yes, we knew there was risk. 100% knew there was risk, but I was willing to take that risk for her quality of life. She died at home, in her bed, in her house, with us around her.
That presentation was probably an emotional one, knowing where we come from. Thank you very much for listening. What we challenge you is sometimes your clinical reasoning, think. Enable risk rather than be risk averse. Thank you for listening to us.
Thank you very much. I just encourage you to let your people do the things. Do all the things. We live with risk every day. Don't let it not enable our people that are already facing their own mortality to not do what is important to them. Thank you very much for listening.
So, Sarah and Helen, thank you very much. I'm now working from an up-to-date script, so I know you're here, Helen. So, thank you. What we haven't got time for now is many questions, but I have one just thought for you. I think OTs, I love the passion of your talk and your presentation, but I think one of the things our OTs struggle with a lot is when somebody wants to use a stair lift and those times and transferring at the bottom and the top. What would you suggest?
Trial all the things, trial the different transfers. let them do it. I mean, I live in Australia, so there's not many stair lifts in our world, but, you know, I did work in England for very many years. I think, again, it just comes down to trialling all of the options, you know, exploring the options. What is the option if they can't get on and off their stair lift? Then they might have to live downstairs. But again, I've had clients that, you know, whose family have carried them up and down the stairs, and that's their choice. And I think as long as we're making sure that we've explored all the options and the person's choosing to use the stair lift, having known what all the options are, then sometimes they just will organically decide that this is too risky now. You know, they'll just use it and then one day go, no, I'm ready to move downstairs. But it's not up to me to decide when that is.
Okay. Thank you very much.